the monoclonal M component, the monoclonal protein secreted by the tumor cells today in myeloma, is with a couple of tests. And two main tests are called electrophoresis, that you can do in the serum and the urine, and immunofixation, that again you can perform in the serum and the urine. Especially serum test, electrophoresis is based on migration of the proteins, and if the polarity, if the charge of the proteins is modified, the migration may not be optimal. So you may have an M spike in the beta globulin part of the electrophoresis migration pattern, which is made of gamma globulin, but very difficult to quantify. Plus, it mixes with the normal beta globulin proteins, and then the exact measurement could be forced by sometimes 5-10 grams per liter, or in the US units 0.5 to almost 1 gram per deciliter, and that's an enormous, let's say, a variation around the real value of the M's component. So this is one of the explanations why the current test for at least IgA isotype, which is at almost 1/3 of the myeloma patients, is very problematic. Electrophoresis has many more issues, not just the problem of migration. One of the other main issues we have now is that most of the patients reach very deep responses. When you reach very deep responses, it means that you lower your M component from several dozens of M component gram per liter to sometimes 1 to 10 gram per liter. But the thing is that the sensitivity of the electrophoresis when it comes to below 10 gram per liter is absolutely awful with electrophoresis in the serum as in the urine. In a world where depth of response is now critically important to demonstrate for drug development, to compare from trial to trial, to explain to the patient the benefit of his treatment and to recommend a treatment compared to another one to patients, and for the patients, because it has some prognostic impact at some point. In a world where all those things are important, you get to have tools that allow you to truly and professionally and repeatedly, with very few mistakes, what we call the CV, a variation coefficient, with a very low coefficient variation, a test that is able to answer the question of the patients and of the people who pay back for the drugs, or for us physicians when we recommend a drug to a patient. And it's clear that electrophoresis is not anymore a proper tool in today's world. A test called Hevylite that is measuring for a given patient a combo Hevylite free light chain together. And the nice thing with this, there are several interesting things coming from that we could get from that test. One of the things, which is probably the most important thing I would say today, is that then you can separate for a given isotype, and I'm going to explain you that in other words in a minute, you can separate what's polyclonal from monoclonal. One of the major issues we face when we measure the intact immunoglobulin coming from electrophoresis was the migration issue. But what we were measuring, part of the issue was that it was non-truly quantitative. It was semi-quantitative. So you had a spot, and you're trying to appreciate the real quantity inside the spot. But the thing is that you were not able to truly measure what's inside. It's a color appreciation, let's put it this way. The first interest of Hevylite is that you will be able to truly quantify. If you perform MRD for 100% of the patient, then the cost is huge for MRD. So my question is that, could that be possible for patients that reach CR to identify which patient in CR we should perform MRD? Because there would be sort of a test in between that will tell if that test is positive, then you do not perform MRD. If that test is normalized, then you should perform, and you have to perform MRD. And then you could split maybe the price and make it less expensive for the MRD price at the end of the day in a given clinical trial or in real practice.